I'll give you a little bit of background about our services to start with, and then hand over to Gerard, who's going to talk in detail about our recovery-based approaches. Jonathan's going to give us a particular practice example, and then we'll quickly look at outcomes. So, just to tell you a little bit about our services, some pictures. We run services across Sussex, so that's East Sussex, West Sussex and Brighton and Hove, big geographical area, and our services have developed and grown quite dramatically in the last 18 months. From what was essentially around 4.5 wards, one was a very tiny ward, to 7 wards. Our secure services are based in Hellingline, which is in East Sussex, near Eastbourne, and Chichester, which is a long way away, about an hour and a half's drive away, where the majority of our low secure beds are. So we currently have, in terms of services for men, we operate 30 MSU places in Hellingline, 15 low secure service beds again on the Hellingline site in a service that's about to move, and 31 low secure services in Chichester, so you can see the spread. Services for women, we've got 15 MSU beds in Hellingline alongside the men's MSU beds, 16 low secure services in Chichester, and we also run a forensic community team across the whole patch, a police and court liaison and diversion service across 6 custody suites and magistrates courts across Sussex. And very recently, the prison healthcare services at HMP Lewis and HMP Ford have joined us, so they're also part of our care group. We based a lot of our work around the time that we were really developing the services, so that gave us a big opportunity but also a big challenge. So we had a big new staff group that we could induct and really work on alongside, I'll tell you a little bit about later, but a sequin last year that's really focused our minds in terms of length of stay. I'll hand over now to Gerard, who's going to talk in detail about the interventions that we worked.
So what we did in our service, where we called what we were trying to do is secure recovery, was to define that as being the restoration of a meaningful, safe and satisfying life, while acknowledging the additional challenges of offending behaviour and the careful management of risk. So for us, we try to embrace that there should be no recovery-free zones, as was recommended, but also we recognised there were no risk-free zones either, and that both of those needed to be accommodated. So that led to fairly significant organisational changes, service-wide initiatives like a biannual newsletter called The Recovery Issue, annual events, a Secure Recovery Conference, service user involvement, staff training, new group work platforms, and high-level organisational leadership was really needed in order to take that forward. But I think what we struggled more with was translating top-down change into the bottom-up change. So what we found was that highly engaged service users and possibly engaged staff benefited from being able to link in, but we weren't necessarily that good at engaging with disengaged service users, and to some extent perhaps disengaged staff. So really, what did it mean at the level of grassroots ownership? So the context of trying to deliver a secure recovery model of care within the provision of the service was what we then started to think about the sequence that came to us in 2012, 2013. And how we would pull those together with a focus specifically around care planning to drive that through. And I'm going to hand back over to Rebecca in our song and dance routine.
So, we had the opportunity of a sequin last year, which was about reducing length of stay. So other people here may have had the same sequence. So it was around optimising care pathways, and we needed to, the initial thing was that we needed to agree a reduction with our commissioners, and that took quite some time to debate, but we agreed eventually with our commissioners that we would aim for, we had to demonstrate, actually, we might aim for, a 1% reduction across all of the secure beds across a year. We also had to include, because we were developing our services, we had a number of repatriations over that time, and we had to include previous stay and the same level of security. So if somebody was moving from a medium secure bed to a medium secure bed, we had to count it from the start of a medium secure stay. So, which was interesting in itself, because it meant we inherited, obviously a number of issues. So we developed obviously a fairly detailed action plan about how we were going to deal with that, and we had some very interesting debates, because certainly at the beginning of the work we had a lot of work across all the disciplines. We had lots of our senior leads meeting together to talk about it, and people found it really difficult to even think about how we were going to reduce length of stay and manage risk safely. So once we had the target, we started with really trying to get to grips with exactly what each admission was about. So we looked at each admission where we were reporting a delayed transfer. I'm not convinced that actually in secure care we're particularly good at recognising delayed transfers, because I don't think we manage them in the same way as other people do. But that we did look at each delayed transfer. I think we're now reporting more delayed transfers as a result of understanding the systems better. We introduced a review by peer MDTs from another team for everybody who had been in any level of security for more than 2 years. So if somebody was in medium secure for 2 years plus, that another team would come in and look at that care. And actually that, again, has been really interesting because it's trying to move it on from being seen as critical, absolutely not critical, but actually to try and move on from the stuckness. And that's something that we're continuing to do. We did a big review of processes, and again, I don't think we've reached the end by any means of this, but review of processes to maximise efficiencies. And that was to try and remember that every day is somebody's life, a day of somebody's life in hospital that may be unnecessary. So about thinking about things like, I'll give you an example, was we would have ward reviews where we'd say, actually this person now is ready for some community leave or trial leave or whatever, and then we'd wait a few days before sending off the letter to the MOJ. So that is building in a few more days to somebody's stay. So it's about trying to get those things done there and then, trying to get the kind of bureaucratic systems in place. I don't think we're perfect at that. We still certainly lose days, but it was about us being much more aware of the impact of that. The standard secure pathway milestones were part of another sequence that people will have worked with, so I won't talk about that in too much detail, but that was about making sure that we had those in place and were working to those. We then also started monitoring. People weren't aware, we weren't enabling our clinicians to understand what the length of stay for their wards or their patient group or whatever were. So we started reporting on that to everybody monthly, internally. So everybody had, for their bit of the pathway, their ward, they understood what the length of stay was, what each individual length of stay was, and what therefore they needed to start thinking about. And then finally, and I think Gerard will probably talk about this a bit more, we started thinking, again with commissioners, and this has come up in a sequence this year, about the impact of our planning of route programmes particularly. So somebody, for example, needing to go through a fence work, if we were delaying that for any reason, then that was again building in the delay for somebody. So it's about thinking about making sure we were providing group work programmes particularly in a reasonable time frame, so that we're there to meet people's needs as and when those needs came up. Okay, I'm handing back to Gerard again.
So what we were really keen on was integrating as much as possible what was required of us, so that they weren't going to simply be bolt-ons that would then fall off when the service lost interest or reverted back to how we did things before. So as scientist practitioners, we started with an audit in 2012 that told us a sorry tale, that we were using an out-of-date CPA process in what at that time was an old medium secure unit. So there was a lack of MDT accountability, and Rebecca's touched on some of how that accountability was able to be embedded at the coalface. There was variable practice across multidisciplinary teams, limited training and guidance. Care plans were not necessarily linked well enough into CPA meetings, and perhaps most damning of all, the sense that patients were both unaware and uninvolved. So we knew that in order to change that, we had to have integrated record-keeping formats, a protocol and associated training for staff, and that included service user contributions as well. Service user involvement in the process to a much greater extent, and also the better use of IT systems. Again, addressing Rebecca's point perhaps about delays, that if you write something by hand, it takes a week for that to be typed up, rather than something happens in the moment and a document is available and ready to be shared. So the process, as I mentioned, involved combining the sequence so that they were complementary, introducing a new protocol with guidance, new documentation, and of course we weren't the only service to be doing that, and I think that the Partnerships in Care very helpfully shared in the network and their model of how they brought that together, but we knew we needed to do something that was specifically for our service. We developed information posters, booklets, leaflets for staff, carers and residents training in MyShared Pathway and the CPA process and regular workshops, essentially MyShared Pathway CPA clinics for staff to attend with their service users. So in advance of a CPA, right, how are we going to work on this, that the care team working with the service user could bring them to a clinic to talk about how to integrate. We introduced ward champions and changed the name. What's in a title from ward rounds became recovery reviews, and obviously we're in the process of embedding that language, but it certainly, I think that it has been something service users have appreciated. And again, as Rebecca mentioned, monitor. There's been a much tighter governance process to drive that, so we've done 4 audits in 15 months. About CPA processes. And of course not all of them make fantastic reading, but actually it's the bad news story when you're not getting to grips with something that we know we needed to hear. So the CPA work, by the way, has just recently, the little badge in the corner that you might not be able to see is a CPA award winner, so it was submitted to the National CPA Awards process and garnered an accolade for its involvement of service users and its clarity. Hence we thought we'd have the gumption to bring it here. So what happened was that there were 8 care plans, or 10 care plans, because there were 8 in the MyShared Pathway work, and then there were 2 additional ones. So we had 3 core care plans: My Mental Health Recovery, Stopping My Problem Behaviours, and Staying Healthy. Then there were other care plans that were linked to the MyShared Pathway, but then 2 additional ones: My Legal Needs, recognising that that was a specific area that could hold processes up, that people needed to own that, and then also the option to have a bespoke care plan, so something that was unique to that individual, that allowed for greater individualisation. Care plans being increasingly written with service users, including their views and all disciplines involved in care planning, so the care planning wasn't something that perhaps the nursing team did, the MDT were doing something else, and those processes weren't joined up. So this is an example of a core care plan around mental health recovery. So we borrowed from the MyShared Pathway structure, where there were 4 questions that were being posed for residents and staff to work with, and under this each care plan, the question of where am I now, where do I want to get to, how do I get there, and how can I tell how I'm doing, with service user and staff views alongside each other. We didn't take on the scoring system that was part of the original MyShared Pathway documentation, but that documentation is available, and some service users do still use that if it's helpful to them, but it wasn't what we required. So that has been going along and been in the process of embedding itself, and as each sort of quarter goes by, or each part of the year, and staff change inevitably, that we recognise that the training program needs to be ongoing. But how we've tried to move that forward in our 2013-2014 sequence is that picking up on the optimising the care pathway, which I think is part of moving on from recovery and outcomes, recognising that recovery can drive quicker and more effective outcomes for service users, and the length of stay agenda coming into the optimising the care pathway process. Obviously all new admissions and transfers would have an access assessment that would then allow us to do the clustering that we needed to do by the medical team. We were set the task of, I think Rebecca mentioned the group work process. We were required to evidence when groups were going to be delivered, or intervention were going to be delivered in these 8 areas. Now they're quite prison offender based rather than mental health offender based, and so we've interpreted it liberally, in other words applying our own groups under what we think that these categories actually map onto in our own service.